So let's turn our attention to second-line treatment. So here's the scenario. The scenario is the patient with metastatic disease has received and benefited from first-line targeted therapy. I'm sure you know the numbers as well as I do. If you take 100 patients with metastatic disease and treat them with frontline therapy, about 80% of those patients have some benefit. About half of that 80% have some significant shrinkage. And about 20% of those patients are what we call primarily refractory. No matter what we do in the frontline setting, the cancer seems to just grow through it. So there's a lot of people that get to second line. And as we've talked, most of those people have seen a TKI. So Dr. George, rationale for TKI post-TKI or mTOR inhibitor post-TKI in the second line setting that sets up some of the results that we'll talk about in terms of how we choose our agents.
So the data, we have good data in the setting, but again, it's really hard to choose mTOR versus VEGF inhibitor based on a comparative data. There's no good guideline as to what's the best at that time. So how I'll discuss the everolimus data a little bit. The study was comparing post-VEGF TKI treated patients, 1 or 2 lines of TKI treated patients were randomized to receive everolimus 10 milligrams daily versus placebo. And the study demonstrated that all the patients had received VEGF TKI and before randomizing, and the study demonstrated that the PFS advantage was favoring everolimus 4.9 versus 1.8 months, and that's the best data after all the patients who received TKI. But when you talk about the axitinib study, that study was done in a slightly different fashion, even though it was in the subsequent lines of treatment. There were patients who had received TKI, and there were some patients who had received cytokines prior to randomizing. So that's a slightly different set of population. And so in the trial readout, axitinib really demonstrated superiority over sorafenib, and but in the subset that who received cytokines before, they had better outcome or better longer PFS from axitinib compared to the patients who had received VEGF before. So it's really hard to compare, and we cannot compare everolimus trial to axitinib trial, and it's really hard to say. But there are some retrospective studies and database studies. Dr. Shueri's and Heng's database studies put out some papers which basically does not guide you in terms of the prior response, the length of PFS from the first TKI to be a guiding factor in terms of choosing the subsequent TKI.
So let me put you on the spot.
Yeah.
So there's 2 patients in front of you tomorrow when you return to your clinic. First patient had a 6-month progression-free survival on a TKI.
Right.
Second patient had a 2-year progression-free survival on a TKI. What will be your choice of agents in person number 1 and person number 2?
So in both patients, I tried to change the mechanism. That's how I would approach it, because you're talking about 2 different biologies. Even though the first patient had a shorter PFS, the second patient had a longer PFS, probably something to do with the biology of the disease. But again, both of them formed resistance to TKI.
Patient number 1, you would do what?
I would start that patient on everolimus as the next
Patient
line
number 2, what would you do?
I would start that patient also on everolimus.
Very good. Dr. Pal, how would you manage those 2 patients?
I tend to be fairly dogmatic in terms of selecting second-line therapy, and I tend to, as Dr. George does, switch MOA in this context to everolimus. Certainly some people will invoke the data from the INTERSECT trial. This was a trial looking at sunitinib followed by either temsirolimus or sorafenib, is guiding that decision regarding selection of mTOR inhibition or VEGF inhibition. I personally think that that wasn't at all identical to a comparison of what would be more relevant to us in a clinical setting, axitinib versus everolimus. My choice of everolimus doesn't just stem from MOA. I also think that in terms of toxicity profile, at least in my own hands, and I think that certainly counts for something in clinical practice, I've just had a better experience overall.
So in those patients that you do start on axitinib in the second line setting or third line setting, depending upon what it is, how do you give it? How often, Dr. Pal, do you dose escalate? They're reporting self-reported blood pressures so that you can get a sense of whether they're having an on-target effect. You have the renal data to suggest that there's a relationship between blood pressure and outcome. How do you deliver axitinib? And you know, it's 5 milligrams twice a day as its starting dose. How do you deliver that in your patient population? How do you monitor it? And how do you take that, whether it's in the second line or the third line?
Yeah, to the greatest extent possible, I really try to stick with the way in which axitinib was delivered in the AXIS trial, and that entails seeing the patient back on 2-week intervals, at least for several iterations, and determining whether or not they have any significant toxicity. At first, the 5 milligram BID dose. If they don't have toxicity, they're escalating to 7 twice a day, and finally all the way up to 10 twice a day.
Dr. George?
Yeah, that's exactly the way I approach it too, just like the trial recommended. But again, following the hypertension is a very valid thing. You know, there may be a relationship between hypertension and the effect, like Dr. Rini rightfully pointed out. There are other pharmacodynamic effects as well, like cytopenias and other things, which could be toxicities, but showing that it could have the effect also on the tumor. So there is a relation possibly with the toxicity.